Gavin Britz, when I got here in 1997, was the first resident I met. And I told Gavin, I thought I landed on Mars because I couldn't understand anything he said. And I said, does everybody here speak Afrikaner? Is that what it was? So Gavin was, he was a wonderful resident. He worked like a dog. He was smart as hell. And the signature thing, as you know, when you look around this department, is I hire people that can operate. I mean, the sine qua non of a neurological surgeon from the UW is they can operate. They're great surgeons, because at the end of the day, it's called neurological surgery. And although people like the idea that you have a grant and a great CV, this is a field that demands great surgery, and that's what Gavin, above all else, is and was and still is, as I understand. So when I took over the job in 2000, when did I take it over? 2000 or 2002, as the acting chief, the first bit of business that I did is I hired Gavin. He had just completed his training. He had done an endovascular enfolded. This is before there were enfolded fellowships. Gavin was on this remarkable course, having been born in South Africa, having done all his schooling in South Africa, came to America, worked at Atkinson Morley Hospital, worked at Johns Hopkins, and then was given a shot as a pre-residency fellow here. He was so amazingly good that Dick hired him as a resident, but I made sure first resident that I met and the first hire. And during the really rebuilding years, really tough time at our program, Gavin was a stalwart. He could operate, he worked non-stop, and there was no case that he was afraid to do. He was instrumental in helping recruit with me Shake, Randy Chestnut, and a few other of the faculty. Then he went off to become chief of cerebral vascular at Duke. Not as fun a place as the University of Washington, for sure, but a great building where he built an incredible cerebral vascular practice and program. He could do open, he could do endovascular. And now I introduce him. I won't take too much of your time. He is the chairman of neurological surgery at Houston Methodist Hospital. Great place, great history, and he is in the process of rebuilding that program. It's a great program already, but one of general neurosurgeons. So Gavin, you have had a remarkable, I would say unique, remarkable career, much like Madonna or the Beatles. We just say Gavin and everybody knows what we mean. He brings a smile to everybody's face because besides his incredible talent in the operating room and endovascular suite, he has a great sense of humor, and you can say anything to him. I hope the residents have time to spend with him because he has a unique perspective, and he'll always tell you the truth. So without further ado, Gavin Britz.
Anyway, thanks, Rich. It's really nice to be here. I mean, I think as Rich says, I mean, I have done pretty well, but I think Malcolm Gladwell's book says that, you know, you've got to work hard, but a lot of it is luck and opportunities as well. And I think, you know, being trained at the UW in a big vascular program, you know, really set me up, and then got the opportunity to go to Duke. So it's not only talent, I think it's a luck and a lot of work. I think that's where I got my success. Anyway, so what I'm going to talk about today, it's actually a sad talk for me because, as you'll hear, what I'm going to talk about for the people that want to do vascular, you should leave right now because it's going to really depress you. So I'm going to talk to you how I've evolved and how the field has evolved in vascular neurosurgery since I left the UW, which is now 2007, and how it's changed. So that's what my talk is really about. So, is it working this slide?
We tried the button. Just push the computers. Where's one of our IT specialists?
Okay. I mean, I can push the slides, I don't mind. yeah, okay, no, it's good. Okay, so that's what it is. So anyway, so why, first of all, people that don't know me, why did I go into vascular neurosurgery? And I think as the slide clearly shows, I thought vascular neurosurgery was the Formula One of neurosurgery. I'm a car guy, I think David knows, I got a whole collection of cars, and the faster they evolve, the better for me. And I looked at vascular neurosurgery as the most demanding, this is a microphone, the most demanding part of neurosurgery. And I liked that, and I thought I needed to go into that field. That is the field you needed the best equipment, you need lots of adrenaline, and to me that's what I wanted to do for my whole life, and that set the stage for what I did my whole time. And as the slide says, I prepared myself pretty well to do what I thought I was going to do, and I trained in the slide says I trained in a really strong vascular program. It's really strong today, but it was strong in those days as well. We were doing over 200 aneurysms all the time. I was doing every open case I could as a resident in regard to vascular, and particularly in England, for the England guys, I'm sure they told you, when I was in London, I'd steal all the vascular cases. I'd come in on Saturdays just to do aneurysms. And, I really prepared myself. At that time, I started developing all the skull-based approaches with, looking at shakes, learning how to do the OZs, looking at how to do the far laterals. And I operated as much as I could to try and be a good vascular neurosurgeon. Britz sent me to the Walter Reed course, for the bypasses. I watched Shake do all these bypasses. And on the side, I learned endovascular. But I was never as excited in endovascular as I was in regard to neurosurgery. As you can see, I'm a car guy that's been racing around VRR at Duke. So that set the stage for my career in vascular neurosurgery. And what I was hoping to do was exactly that. I thought I'm going to be this Formula One racing car driver, doing the traditional cardiac Stansel cases, as Shake and them used to do, the clipping of the giant basilars,
just a corner
doing the big vein radial bypass grafts with the aneurysm, doing the 20-hour operations for AVMs, and this is what I plan to do and prepare myself to do in my career as a vascular neurosurgeon. This is technology. And early on in my career at Duke, I did these. I almost perfected vascular. I think people that have done vascular long enough, you can never really perfect the cases, but these are the cases I ended up doing. We did these basilar bifurcation aneurysms, under adenosine. I did the radial artery bypasses. I did the post-circulation bypasses. And also improved my endovascular skills. But during that time, I truly perfected what was old vascular neurosurgery that I prepared myself for. And things have changed. When you look at 2010, this is what I feel like in some respects now. So with the vascular, I trained with my whole emphasis in developing the operative microsurgical skills, and this is what it looks like. And sometimes I feel like that as the field has evolved. And this is how I visualize. I'm an endovascular guy as well, but this is how I visualize endovascular versus vascular. I was trained, these are the real men, these are the nerds. And I had these two fields, and I really, as Rich knows me, I wanted to be the real man. There's no ways I want to be the nerd. So I focused on developing the open vascular surgery, and that was the basis of my career, doing the endovascular as a part-time things. Now, I look around, instead of driving the Formula One car, I'm riding a go-kart. That's what I'm doing now. I'm no longer the Formula One racing car driver doing the complicated vascular, because it's changed. I'm now riding the go-kart, still doing some cool cases, but it's truly a different perspective on how vascular neurosurgery is. Obviously, you've got to take a step back and say, wow, I've done all these years, I did a 3-year residency, I did 2-year fellowships, I did endovascular, what's changed in the field? Why did I prepare myself so poorly for a career that I thought was going to be really great? And I think you look back, why? And this is why. I think for the residence technology, there was the disease process that was part of the vascular, and having catheters that can navigate the cerebral vascular system and get there and clip the aneurysm, call the aneurysms, was the way of the future. There's no way someone would want their head open when they can have this. And these two people really set the stage for endovascular therapy. The first was 85 and Brown, described the first coiling, and I think the Guglielmi coils, where you can go inside, place the coil, detach it, manipulate it, allowed us really to take endovascular to the next arena. In contrast, so why did this happen? As mentioned earlier, regardless, there's been lots of advances in microsurgery. Shake knows very well. Microscopes are better. Anesthesia, except for Art Lamb, is better. Better neuroanesthesia, better lumbar drainage, skull-based approach, semi-clipping. But when you look at the fact is, you've got to go inside, open someone's head, manipulate the brain, and for ACOM, we take gyrus rectus, sometimes it's still an invasive procedure. So when you compare these two, what would you want to have done, that versus that? So that was a driving force of what destroyed my career in vascular neurosurgery. But you look back further, we've really come a long way. And for the residents, in 1784, ligation of carotid artery was the first treatment. Horsley exposed the aneurysm in 1885. Harvey Cushing developed the silver clips in 1911. Norman Dott did the first wrapping of an aneurysm in 1931. And then Walter Daney did the first clip occlusion of an aneurysm as we know today. For endovascular, the early phases were endovascular occlusion, direct puncture aneurysm, Manee, where the angiography was great, Lisnov, endovascular approach, vascular lesions, Rothenberg, and Sabenko. This set the stage for development of the endovascular realm. But I think the acceptance of the technology at that time was difficult. And I think, as with most technologies, there's generally 5 phases. There's the awareness, interest, evaluation, trial, and then adoption. And I think for endovascular, when we were in our prime, I think even Lewis in that area, we were looking at endovascular, even though we were doing it, still looking, oh, that's a pretty cool device. We got interested, you go do your fellowship, then we started evaluating, do the trial, and then finally you either have to adopt it and evolve, or you actually die. But, that's a trial that really changed treatment of aneurysms, but there was, as I mentioned before, a lot of hesitancy, and I was one of them. I wrote the editorial for The Lancet, and even though I'm an endovascular guy, people said, you were criticizing that trial, and I really did, and looking back now, I was probably wrong, because I did it on an emotional basis and not an intellectual basis, and when you do that, you're always wrong. But I was really upset, writing was the wall, but that set the stage for how my career changed. Just to give you guys an example, so 2 of my Duke guys with me, I was doing 600-700 cases a year, which includes angio, but I had a full vascular practice. This is what I used to do almost every week, okay? That's 5 years ago. So in less than 5 years, and Sheikh may disagree with me, but I think this disease is gone. So these are the cases I did. Big paracrine aneurysm, fine vein bypasses, red light, artery bypasses. So this is what I really love to do. This is what kept me going in the mornings, kept me going, operating all the time. But unfortunately, that is gone. And the reason being, this is what's happened in the floater version. This is a lady that came and saw me. She actually was going to go to Australia. She said, look, Dr. Britz, I've got an appointment to fly out in a week's time. And she saw me with double vision. So we got the angiogram, and I showed her this. I said, well, there are 2 options. I said, we have floater version, or I could do a bypass. I'm not going to go clip this thing. And what did she choose? Floater version. She went on a trip the next week to Australia, and there's no ways I could have got the same result with a radar artery bypass. Because I think complication rates are still 5-7% for radar artery bypass or radial bypass. So that's why in 5 years, what I love the most is now what I do, but I do not love the most, but it's better for the patient. And I think as for vascular microscope, this slide is for you, Sheikh. This is what we look like. There's always something lurking in the background to take away more cases that we used to do in the OR, but that's part of life. So obviously, again, even though endovascular guy, I think it's a good thing. Endovascular is here to stay, and the reason I say that is because the treatment has been never been worse than the disease, and for aneurysms it's no different. For the rest, it's just a little introduction about that. But I think when you look at the endovascular versus the open vascular, there's no ways what's driving the driving forces of this technology is number one, technology, is microcatheters, but also there's no doubt in my mind doing both that endovascular is a safer procedure for the vast majority of patients. But as you can see, my tie is a clip tie, and this is one of my favorite people. And as he said, you have to have enemies in some respect. If you have no enemies, you haven't stood up for anything. And I still say, and Sheikh knows when I go and talk nationally, I still say clipping is important in certain patients. But, again, this is me, endovascular is the way of the future, and it's changing rapidly. So example, this is a classic example of how things are changing. I know, don't you guys are the stroke neurologists here, but when we say to the stroke neurologists in January of this year, we need to do thrombectomies, they would say, no, it's immoral, you're killing patients, you guys are crazy, crazy, crazy. That is in January. What happens in February at the IC meeting? 4 trials recently came up that showed that thrombectomy really works, and it's a significant difference. So within January, now all of a sudden, we have a breakthrough in stroke therapy, and stent thrombectomy is the way to go. So that just shows you how it's evolved. This is actually 2 years ago. Lewis, what was your feeling at 2 years ago? We did the strokes, but people weren't enthused about it. But now, it's crazy. The last, since February's IC meeting, we were up at night, every night doing stroke therapy, which I don't really want to do, but we're doing it. And this is the reason why. So that just gives you an example of how the technology in vascular is changing within a few years. So when I started at Duke, minimum, but this is what it is now. So the big question for me is now, how do I approach particularly aneurysms? And I've kept this principle my whole life, the KISS principle, not the bang, not the lips, but understand when I look at a patient, what's the best for the patient? What is the easiest and what is the simplest? And I think, as I said before, important to understand the match history. I'm not going to details, but for the reasons, this is part of it was discovered in England, Atkinson Morley days, rupture aneurysm, 4% the first day, 1 or 2% a day for the weeks, 30% in 3 to 30 days, about 50% of patients rupture in 6 months, 3% thereafter, and a 70% mortality at least if we treat these. So therefore, we treat these. For the unruptured, it's a little more complicated. I don't think we have the data because, as you know yourself, you find small aneurysms that are ruptured, but this is a generally accepted risk ratio, a 5-year risk for size and location and number of aneurysm family history. That's largely size, 7 to 12, 2.5% over 5 years, peacock VAS at 14.5, and then going up size, and for giant aneurysms, 50%. So for unruptured aneurysms, I particularly am very, very careful in saying what is best for the patient. Number one, do I need to treat the aneurysm? And if I do need to treat the patient, what is the best for the patient? Also, as you look at endovascular and vascular now, you have to address what are the options available. And I think you have to look at everything available for every patient, which is actually a luxury we have now compared to before. You know, in Dr. Wynn's days and all those old days, Spetzer days, it was a clip, that's all it was. Now we have simple coiling, stent-assisted coiling, balloon-assisted coiling, we have flow diversion, and vessel sacrifice, just in the endovascular arena. In the surgical options, we have flipping, we have flip reconstruction, trapping, and bypass. And these days, when you evaluate a patient for an aneurysm, you've really got to decide what is best for the patient, and this is what I can offer the patient. And being a dual-trained guy, this is what we can do for these patients. This is a slide, a schematic showing the different tools available. You know, there's the clip reconstruction. Shake, this is one of yours, I stole by the way. The bypass, coiling, stent-assisted coiling, and then flow diversion. So how do I do it? Because I'm going to give you a few cases now before I go. But this is a lady that presented as an unruptured vascular aneurysm. What are the options? She's 45, she was pretty young, unruptured. I guarantee you 10 years ago, or actually before the stents, she had a wide neck, she wouldn't be coiled, she'd been clipped. Okay, these days, there's no doubt, and there's no question I would go treat this endovascular. She gets a wide stent, gets the coil, and goes home the next day. So this is how I look at patients. What's best for that patient? At 45, most people say, well, the recurrence rate for coiling is bad. But I still think for a VAS, and I do VASs occasionally now, very occasionally now, endovascular is really the way to go. Most of us that do vascular, say for vascular aneurysms, unless you cannot do it, it has to be treated endovascular. But again, as I said before, clipping, this is a guy who came in with a ruptured pericallosal, very, very broad base. I can guarantee now that some endovascular guys will say, well, this I can put a stent inside, I can spend 5 hours putting balloons inside the pericallosal. That's ridiculous. This is a case, CTA, 45-minute case. So again, this is a situation where I'm going to clip it. But again, for that specific patient, this is what I need to do. Keep it simple. Don't try and make things complicated. And that's what you need to do. So in summary, you know, for my data regarding my clinical practice, for ruptured aneurysms, I still treat about 50-50. But unruptured, I should have showed you a graph. I treat about 90% of unruptured aneurysms now with endovascular. And really, the only ones I'm doing are the ones that need a bypass or the MCAs that are really wide-necked. Because the rest, with the new stent technology, flow diversion, you can treat them endovascular. And this sums up, you know, how I overtrain for a field that doesn't exist anymore, which is pretty sad. But as I said before, you know, we're still neurosurgeons. As Rich said, we had to operate. In regard to flipping, there's a rapid move to endovascular therapy, but we can still improve outcomes in regard to open surgery. And I'm going to give you a few examples. So when I started this field, you know, as a resident, still keen on vascular, we did the cardiac arrests. We look at those things, traditional cardiac standstills. This was cumbersome. We used to call the cardiac surgeon, we used to call LAM, having him on standby, you know, fem bypass. Remember those cases? You know, drain the blood. But those complication rates, I don't care what you say, in whose hands, were huge, and at least 50%, okay? I know Sheikh likes temporary clipping. I'm not crazy about it, but my feeling, it limits space, main-induced spasm, I think increases the stroke rate. So these are things that are around for vascular before we change them. Then the alternative, which I actually started developing up here, and then David and myself wrote, we were one of the first pioneers of this. We use adenosine, which is a drug that cardiac surgeons have used. We go inside, give the drug, stop the heart, allow us to collapse the aneurysm, and get the results that we could have had for the traditional cardiac arrest without stopping the heart for more than 30 or 60 seconds and get the same result. So this is an example of how we've taken the open vascular field to a different level, and it's allowed me to do more complicated cases without having the complications of fem bypass. And I think David and myself, we did tons of this. How many did we do? Tons, eh? So we did a lot of these cases. And then that's a technique for people that know. We started 6 milligrams, it's been published, but we can get a really good result. Just to show you how it works, so I think as Sheikh and the vascular guys know, if you want to be a good open vascular surgery, you want to be patient, and you've got to really circumferentially expose the aneurysm, look at every branch, look at every perforator. For a small aneurysm, that's no problem, but for the larger ones where you cannot get around it, like this one, you're going to get a stroke. What does adenosine do? It gives you this picture, and I guarantee now, once you've got this picture, because what I found is the walls usually adhere into the brain, usually adhere into the structures, and once you collapse it down a few times and release those adhesions, this is what you see on the final dose. And obviously, in this situation, go inside, seal the branches, and put your clip inside. This is an operative example of a PCOM we did. So that's the skull base for the resonance at the thyroid. That's the ICA, that's the A1, that's MK, and there's this large PCOM. So before the adenosine was around, this was partly thrombosed. You say, wow, how can I see this, the choroidal? How can I see that? And then I'm taking a number 4 Penfield and pushing as hard as I can down, and that's the distance it gives me between the skull base. I give adenosine, I collapse it down. Now I can see the perforators on the brainstem, which gives me a great visualization of the aneurysm, the branches, and then we go inside for a clip. This is an example of how it makes my surgery better as an open vascular neurosurgeon. And I'll give you a few cases that I've done. This is a lady with a large ACOM, a guy with a large ACOM, and presented with subarachnoid hemorrhage. I can guarantee now, if I call this, or the subarachnoid hemorrhage, I'm going to have a bad outcome. If I clip it without adenosine, I'm not going to have a great outcome. But without adenosine, with adenosine, I can really see my structures. And this is the type of result you can get with adenosine. This is a case, again, clip reconstruction. This option was a ruptured aneurysm. Either go do a bypass and shape, I've done that. But I said, well, let me first try adenosine and use a whole lot of fenestrated clips and did a clip reconstruction, and that's the final result. So again, you could, even in the open field, even though it's changing towards endovascular, there are still techniques available, and we can modify these techniques to get better results in the open vascular. This is another guy came inside, this is actually a Duke. This is a large PCOM that Dave did with me, thrombosed. And I said to myself, well, am I going to go bypass electively? Went inside. And the nice thing about this, the neck was smallish. And when I gave adenosine, there was enough for me to collapse the aneurysm down, put a clip, and even preserve the fecal PCA. So again, the adenosine makes a difference. And I showed you this slide before. This lady presented with mass effect, unruptured within the brainstem. I still don't think there's, if there's mass effect in the brainstem and the vascular, I think you clip this, stop the heart, clip that, achieve it really, really well. So again, the adenosine has really taken open vascular surgery a little bit further. We're not competitive with endovascular, but it's really made things a little bit better. And you go to endovascular, we know the results are better. I mean, we read the trials, but is it the panacea of aneurysm treatment? And the answer is no. And I'm going to give you some examples why I say that. This is a kid that actually came to me just before I left Duke. And this kid, for the resonance, has got perirhombic syndrome, so it's a book report for you guys for next Wednesday. And this guy presented with some blindness in the left eye. So he had his MRI scan, had his CT, and he had this fusiform aneurysm of the ICA. So obviously this is a really tense family. They flew all over, Dave Ferrello, Spetzer, all over, came around, but they were from North Carolina. And they said, okay, well, what would you do? Well, I said, we need to bypass you. I said, this is what I would do. It's a fusiform aneurysm. Then they flew around. They said, well, either you're going to put the pipeline in, or I'm going to go elsewhere. I said, okay, fine, we'll do it. The patient told me exactly, which is a bad mistake. But anyway, so we did that. So that's the angiogram, which shows this aneurysm. We went inside, and for Lewis, let me show back. Lewis, you know how hard that was to purchase that. So we did purchase the pipeline from distal, brought it inside, but finally, after struggling enough, we got a really nice purchase of the pipeline device and the post of angio. So it shows some stasis already. So we thought we were pretty cool, but a month later, the kid starts losing vision in the left eye. And I said, well, what's going on? There must be something going on. I bring the patient down to angio. This is a young kid, 9, 10, and we repeat the angio, sorry. And the aneurysm is completely gone, okay? I said, well, maybe it's bullshitting you or something. So I sent him up to ophthalmologist and classical bitemporal field cut. So this can get worse. We get his MRI scan, and this aneurysm's got bigger. Serially, what happened to make overball this case, this continued to get bigger and bigger and bigger, ended up needing a bypass. So even with flow diversion, it works really well. And I've got a case now that ruptured in a delayed fashion as well. It's not completely the answer. This is another example, and I think Lewis myself alluded to it a little earlier. Siddiqui, I put my patients with his and the Buffalo group from Duke. And this is the results for these large symptomatic dissecting vertebral vascular aneurysms. We had 7 of them. We placed the pipelines in them. Look at the results. 4 patients died. Other 3 had MRI scores of 5. Okay, and this was my conclusion to that paper. I presented this to Siddiqui once, you know, results, 57% clean kill, 100% complication rate, and when you're comparing to this gentleman from Portland, the only difference was the tool. He used the selection, and I done it myself, you know, used the pipeline. So again, you look at the pipeline for the endovascular, you know, pipeline for the dissecting post-circulation aneurysms, that's not the answer. So we've still got work to do. So it's not the thing. This is a case I did last week. As an example, so this is a lady that came in, actually was in Florida, ruptured a month ago. She saw Brian Ho, and then, I don't know, she got better, came to Houston, I don't know why. We got an MRI, a CT scan, clearly showed a bad bleed, and but she was fine. And she had this little aneurysm of the A1. So I said to her, well, you know, you're ruptured, you know, we can treat you, I can clip you. She also had a carotid occlusion on the left-hand side. She had no carotid. And she had, when I did the angiogram, she had femoral artery occlusion, aortic occlusion, etc. But I still said to her, you know, she was 77 and the ruptured aneurysm, and the CTA looked like a beautiful neck. With the carotid gone, I said, well, we can clip you, but you know what, it's safer to do a coiling because I can do this pretty quickly. I went inside after struggling to get up there on first run, and I had an MRI which showed she did have an inferior division. Get the first run, there's the M1, inferior division's gone, there's the aneurysm. So, you know, so it shows you the endovascular. So what I do is I say, well, she's a ruptured aneurysm, I can't give her thrombolytics. We go inside, call the aneurysm. By the time I call the aneurysm, the whole M1's gone. But with the new devices, went inside with a stent retriever, open up, and she's going to walk out the hospital. But again, you know, endovascular is not without complications, but at least we've evolved now to be able to deal with the complications. And I can tell you now, before the Selena technique was available, this would have been a disaster. I mean, now, I think, what's your success rate with thrombectomies now, Lewis? And Shay?
Over 80%.
It's exactly, and that's the difference. So this is a situation happening in angio, and I guarantee now, when I trained, or even until 2 years ago, if this happened to me, I would have said, oh, my day's done, you know. But I mean, she's going to walk out here. But things have evolved, but it's not obviously not perfect. I think vascular, though, you know, I'm obviously giving you a bit of a depressing talk. It is exciting, and I think some cases we do not have a solution. I think I alluded to it last night with Lewis, and this is one of them. This is a guy that was also just before I left Duke. I followed him for a year. This is a 42-year-old guy, had this large dissecting aneurysm of the basilar, massive effect. He was dysphasic, he had palsies, he was bretic, and I watched him decline over a year, and I said to him, you know what, we really don't have an answer. And I just done that pipeline series, and I said, we're not going to put a pipeline in you. I said, well, let me try something novel. Sorry. I know, and so I said we did this. So I said we did an angiogram, and this is what it found. He had no PCOMs. He had this obviously clearly dissecting aneurysm of the basilar, largely thrombosed and calcified. And I think what was causing his symptoms was he was knocking off the perforators plus the massive. So I said to him, well, we're going to try something innovative. Up to now, people have done a whole lot of things. I'm going to try something novel. I'm going to do a radial artery bypass, and then I'm going to endovasculate through the vertebral artery. And if the dissection is prograde, how about if I occlude this vessel, do a bypass here, get the flow to come down the basilar, won't you get better? And that's exactly what I did. We did by bypass, there's the flow in the basilar coming up, patient got no better. He actually got worse. He's still alive, but this is a disease that I don't know at this time and day what the answer. We can talk about it after. This is the one disease that I'm going to try and focus on in the lab now, in the animal lab, trying to cure. But this is the one disease in vascular neurosurgery we have no answer for. We try this stuff with current techniques don't work, even with the most sophisticated bypasses or the best devices, patients still do badly. This guy didn't get any better. I think in some cases we still need to push the frontier as well. And this is a case that I've just written the series now of these, and we're going to get published. This is I'm not sure this is a lady or a guy, presented with acute brainstem stroke in the brainstem, occipital lobe. We get the angio, but no vertebral arteries. All he's got on the angio, he's got a little bit of trickle of his basilar down. He's got bilateral vertebral occlusion, and he was having literally vertebral basilar TIAs every time he stood up. I've got 3 patients like that. So went ahead, did a bypass, and there's the basilar now putting all the way down, and that patient did well. So of those 3 patients I did with basilar occlusion, Shaker, I think, reviewed the paper, but it was, you know, 1 did really badly, that's life, but 2 did really well. So I think there's certain cases that people may say, this is crazy, the basilar's gone, why can't I operate? But I think with really good neuroanesthesiology, which I had at Duke, you know, you keep the pressure up, you can do this bypass technically, and some people will do well. I mean, not everybody, but again, this is pushing the frontier of neurosurgery, and I think that's what we have to do as open vascular surgeons as well, and that's exactly what we did. So my clinical summary before I discuss the research is that we are doing relatively well with aneurysms. We really are. I think over the last 12 15 years, we are getting much better results, and we're excluding the aneurysm well. But I think the one part of the field that hasn't got better is our understanding of why our subarachnoid patients still do bad. No one truly understands. If I ask people, even smart guys like Dr. Lamb, no, you're going to think I said Dr. Lamb, but why people die from subarachnoid hemorrhage? We don't really know. We say hydrocephalus, brainstem compression, but really no one knows. And there's still a significant mortality, but I think this is the one area that I think there's a huge underrepresented morbidity. And I think particularly the subtle defects. I think, before we used to slip the peacock for the attorney, and he'd say, you know what, I'm alive, I'm doing well, but I'm just not the same. We used to say, well, that's because we retract the temporal lobe. Now we have endovascular techniques. We go inside of the micro with the catheters, don't disturb the brain, and even those patients are saying, I'm not the same again. So that's what my lab has been focusing on. So I think the frontiers must both be in the operating room, in the endovascular suite, but also in the research arena. So my laboratory, and this is Joe Menos here, which is, he started me off on this, and it's focused on two puzzles. The one when I was here in Seattle and at Duke, and what I'm focusing on now, septic flow following subarachnoid hemorrhage. But I'm going to give you a brief overview now, what I'm doing. So getting back to the first hypothesis, what we thought, well, people aren't doing well because of vasospasm, strokes, etc., which was true. But I think one of the parts that was neglected is that the hypothesis we had in the lab was the microcirculation. If the subarachnoid hemorrhage is affecting the brain, how is it affecting it, and what do these small vessels do? We know the small vessels would control CVF. That's where we control reactivity, vascular integration, and CVF. And our hypothesis in that lab, and Joe and myself remember that very well, we think that if you have worse microcirculation spasm, you're going to have small artery strokes, worsening effects of the large vessel spasm, and morbidity. So that's been the hypothesis that's driven the lab that I've been up and down running for the last few years to try and understand why. And for the residents, why is it important? One of my friends going to divorce, so he needs one. He's serious. He's like, he's going nuts. He's sleeping with a glove. Anyway, and why it's important is that small arteries are where it all happens. This is the end point where we control CVF. It's integrated but involved in vascular communication, and we have the neurovascular unit. Not going into detail, but this is important. So our hypothesis was, Joe, you affect that microcirculation, you're going to affect all this, make things worse, and get some strokes. What hypothesis supported that? Obviously, since we started, which was many, many years ago, new papers have come out that have shown that that's probably true. As we've shown, ischemic deficits on MRI scan without having any angiographic vasospasm. Some in the OR in Germany recently showed, one recently, 98, showed that field circulation was extremely hyperresponsive. We have intraoperative evidence with optical imaging for microvasospasm now from Germany. And again, this classical paper, which we always quote, is that there's small vessel strokes on MRI for subarachnoid hemorrhage. So this supports what the lab has been doing all these years. So this gets back to Joe's phase. And Joe, thanks for coming. But the first question we did was, well, let's start proving this whole hypothesis. And the first, for the residents, we get to look at the vessel. And the most easy thing was to do, because Joe and Alan did the cranial window, we took these rats, we did the endovascular subarachnoid model, we did the cranial window prep, we got some invader data, we stimulated the sciatic nerve, and obviously if we stimulate it, the vessel should dilate to the metabolic demands, and we can measure really crudely the caliber of the vessel. That's how it all started many, many years ago. And we published this, and you can clearly show that post-subarachnoid hemorrhages, these peeled arteries, which are the first phase of the microcirculation, was completely abnormal to any of the neuromodulators. And so we knew we were onto something at that time. We then went on, well, if that's the case, Joe headed this part of it, was we said, what about the penetrating? These are the arterioles that leave the cortical surface, go into the white matter, and to me, those are the most important. So we did the endovascular model again, and we did what was called an isolated vessel prep. Invader data, again, do the same thing, have endoluminal flow, and measure the caliber. This is very crude to what we're doing now, but this is where it all started. And what did we find? The same thing, obviously published, showed the same thing. The penetrating arterioles were completely abnormal. So now we had data that both the peel and the penetrating arterioles were completely abnormal. We looked at some mediators, and the same thing, looking at all the different mediators, clearly showed we were onto something. These vessels are not working well, and they were depressed for at least 2 to 3 days in animals. And subsequently, Duke, we've shown that it even lasts up to 30 days. So the third question was, well, is this a physiological abnormality, or is the microcirculation affected structurally? And that's what we did. So we looked at, and this is still from Joe's work, this is really early on. Basilar artery, that's what it looks like. Internal corrugation, which is spasm. The middle cerebral, and that's the arterioles in the temporal lobe that Joe could remember. So we had now clearly showed the penetrating arteries abnormal, the PL arteries abnormal, as well as having a structural defect in these vessels. So what does this mean at this stage? Is that I think there's growing clinical evidence that the microcirculation was important, but more importantly, this may account for the subinducer deficits and can include the temporal lobe problems. So obviously, why did I say that hippocampus? I think this is a huge hippocampus program. I need to tell you about this, but this is a very, very important area that controls and has widespread connections with the brain. But the very important thing, going back to Foyle's paper, this is an area of the brain that's very vulnerable to ischemia from trauma, as well as strokes, etc. So if you have a microcirculation problem, the hippocampus is going to be down. So relative to other regions, the hippocampus is particularly vulnerable to ischemia. So you take a step back, the hypothesis was microcirculation, subarachnoid hemorrhage, microcirculation gets affected, you have an area of the brain that's really vulnerable, and if that gets affected, we can have hippocampal loss, and that's going to lead to the executive function dysfunction. And so the next phase was to show that, and this is, we've clearly shown, that's the sham, that's the 2 days and 7 days, as you can clearly show, there's been cell death. So now we showed PL penetrating artery structural changes, as well as having clear evidence of cell death in the hippocampus. Obviously, there's many interfering variables in this. This could be from the ICP, from the hydrocele, etc. But we have some data now to show that we may be onto something. When I went to Duke, obviously it's very hard to start labs, and Duke, I was really busy, but we did some work in that regard, but I'm getting back going now. So what we did was so Dennis Turner and myself, we became friends, and I said, Dennis, you do optical imaging, let's look at the hippocampus, but that's what I'm really focused on in regard to, how good the blood supply is. So we took these rats, and this will get published, it's in the process now, take the neocortex, expose this large hippocampus, and we just did very simple recordings. We looked at oxygen recording, and we did stimulation. Okay, so that'll be inside and outside, and that blue just as you stimulate, and you can decide where you're going to put your electrode. So this is just an example. That's what it looks like. In the stimulation region, you stimulate, and the oxygen probe will pick up an increased demand. The oxygen potential will go up in the tissue. So that will tell you exactly the hippocampus is working well. You're stimulating, increased demand, the vessels dilate, and you'll have that response. And outside is first a dip, but then it goes up. And obviously we published that showing that this is an indirect measure, not a direct measure, but an indirect measure of how we can measure this CBF in the hippocampus indirectly. So we hypothesized that if it's decreased, you can have a decreased oxygenation level. And this is exactly what we found. So just to recall the normal response, that's the oxygen tension. It dips down, goes up. What do we find in post-subarachnoid hemorrhage? First of all, the oxygen tension was extremely high, and instead of having a response, it goes high, it actually dips down. So people say, well, how does this work? If you have ischemia, why is your oxygen tension going to be high? And I think our hypothesis is that if the vessels are completely in spasm, there's no auto-regulation, so you increase in oxygen delivery, and even that can result in toxicity. So we realized even at that time that's very important, and we're doing in vitro slices, which Dennis is doing now. So essentially at that time of this whole experimental process, that we really know now there's the microcirculation not working, and we know that the hippocampus is particularly vulnerable, and we have an indirect evidence that post-subarachnoid hemorrhage we have problems with blood supply. So obviously I don't have the optical image equipment and Houston Methodist, and I've been there 2 years now, cannot believe it. But we have a beautiful in vitro microscopy. So I said, well, that's better than Joe Mena. I mean, Joe Mena cost me a certain amount of money a year. The in vitro microscopy is $2 million. But I'd rather have Joe. But anyway, this really can show me the vessels, non-invasively, and in vivo models. So I said, well, let's do this. So when we started looking at the vessels, we developed the model, we had the perforation model initially, but we said, well, let's do what most people do now, the cystoid magnipuncture, and we looked at how it goes, just for the resonance, the CSF circulation. Now, CSF is very important. We think, what is it? I mean, the CSF, as we understand it more, provides buoyancy, but I think also it provides a chemical balance in the brain. And it almost is regarded as the toilet or the flushing system that flushes out all the stuff. And I think people that know the science, Niedergaard talked about the G lymphatic system and regard how the CSF is a part of a G lymphatic system, and if that gets abnormal, people may develop diseases. She even thinks that the way we recover from sleep is by lying down, you get more CSF flow around the small spaces, and that's why it's important. So we said, well, let's look at that in regard to the microcirculation and subarachnoid hemorrhage. And just to give you a schematic, this is one of the postdocs that did this. Hold on. Sorry. Anyway, so this is what it looks like. So in the brain, you have the artery, you have the vein, and you have this interstitial space which is around the vessel, and that's called, it's a smaller version of the Werker-Robin space. And that's Driffel, like he was in Seattle. You remember him, Dr. Lamb? Remember him?
Who?
Jeff?
Nope.
Joe, you remember him. He was one of the scientists out, and he's now in Portland. He's done a really good job. Anyway, so he also is working in the same arena. And what we're saying is that the way the brain clears itself from metabolites is that the stuff comes in the artery, diffuses out here, and then comes out into the vein and gets transported away. That's what it looks like. So that's what it looks like. So now the question is, how does that get affected by subarachnoid hemorrhage? So what we developed, we use microspheres, we inject into the cisterna magna, and we track the progression of CSF. And so it goes around there, and we did the classical film. This is my postdoc doing this, but and we have this, the classical model, and that's the in vitro setup. And what we found, this is the data. This is what it looks like. So that's the normal, the dorsal, the ventral surface of the brain using different microspheres. And as you can see, when you inject these microspheres, the CSF flows not in the traditional routes, but also it flows along the blood vessels, and that's what you can classically see. So that's what normal CSF flow looks like. When we do the subarachnoid hemorrhage, it's different, and you actually have what this is compared to the control and the subarachnoid hemorrhage. You actually get a complete CSF arrest. People say, well, they get hydrocephalus. That's true, but what I'm talking about here is the CSF around the small microcirculations. Even that's the blood that the CSF that flows along these small vessels is completely arrested. So our hypothesis is that if the CSF is completely arrested around the small vessels, we cannot get rid of metabolites that need to get rid of, and that will result in transneuronal cell death. And that's where we are now. And the thing about this, talking about 3 days versus 30 days, these effects are lasting, we've got 4 papers coming out, are lasting up to 30 days. So even 30 days after giving the subarachnoid hemorrhage, these animals are still do not have normal CSF flow along the vessels. And this is the long-term effects again. And to give you an example, it looks like he's got the videos, but I'm not going to show you. But that's what we look at. This, that's the vessels as well. That's normal. That's a normal after subarachnoid hemorrhage goes into vasospasm. And then we do these. I'm not going to show you this, but basically just showing the microcirculation. I'll get you that now. So the question is what's the relationship between the microcirculation and the CSF flow? Because we know that these vessels are very important, and the CSF flows along the vessels. So one of the hypotheses is that is the vasomotor action of the vessels driving the CSF into that perivein space and allowing the CSF flush to flush out and take a nap. So obviously, being a microcirculation guy, we said, let's look at that. So now we've looked at that as well before subarachnoid, and you can see, looking at the flow, they're completely abnormal. And that's just, let me show you, see if we can do that. But that's what it looks like. We're doing these scan lines, and compared to subarachnoid hemorrhage versus normal. Sorry, this doesn't work. But anyway, just in a summary, the peel circulation, even with the in vitro microscopy, is completely abnormal, but also the vasomotor action, which we feel drives the CSF in those Werker-Robin spaces, are completely abnormal. So that's where we are now. So as I said, I've been there 9 months, so we just submitted an R1, was scored, not funded, but that's where we want to land now. So in conclusion, for the vascular, I think subarachnoid hemorrhage triggers this bad response. There's definitely complete arrest of CSF, doesn't allow flow along the small microcirculation, and my hypothesis is that affects the metabolites, and we can get transneuronal cell death. So that's where we're going to go now. When Phil joins us, we look at this, some other stuff in regard to that as well. Anyway, thanks very much. But I think vascular is still exciting, but it's definitely not driving a Formula 1 car anymore. It's definitely driving a go-kart, and I think we push the frontiers in research, make things a little bit better. Questions?
Questions? I can't imagine people are speechless after Gavin talks.
You don't know anything.
Yeah, that's great. Joe Menno, do you still have the prep up there in the lab?
Yeah, the golf prep. That's what he has. He's got the wedge, the foot wedge.
It's PTSD from your Harvard Hall back in. Gavin, great presentation and welcome back. I wanted to talk more about the evolution of vascular, or the open versus endo, and how do you see, and you were fortunate to have all the opportunity to train and get to the skill level that you accomplished in terms of open procedures, but how do you see the environment changing for our up-and-coming trainees?
Well, I think I've got a slide. That's what, Joe, that's what I was going to add that, but anyway, that's a good question. I think for me, the biggest concern is, and I was speaking to Fred Meyer last, I think 2 weeks ago when he was in San Antonio, they are training, but sub-programs that are doing 25 aneurysms a year are training 8 fellows. And if you look at the current data of how many people, that's both neurosurgeons, radiologists, and interventional neurologists are trained now, not tomorrow, which is going to be another 20, 30. They will, and you do all the aneurysms in America, there's going to be 10 aneurysms per person, okay? So what worries me for the future, obviously with stroke care, there's going to be huge opportunities, but the problem is no one wants to do stroke, they want to do elective aneurysms. So what really bothers me is that I think it's going to get so bad. I mean, I do, you know, when I was at Yale, I did vascular, some skull base. At Duke, I did 50-50, hey? No, about 60-40, a lot of skull base. I'm now doing about 70-80% skull base intrinsic tumors and vascular. First of all, we're 4 people. But and we do, you know, 250 aneurysms a year at Methodist. But the difference is the field has completely changed. I mean, it's just, you know, I had a resident Taylor who was going to go to Hunt Badger for a 3-year fellowship, and I talked to him out of it. I said, Hunt, you know, I'm worried about the future. There's too many guys around. So, you know, as the numbers of many specialties have shown, if you're not doing the volume, you're not going to have the outcomes. And the problem is people, it's all about money driven. You know, CPT code's the same for outcomes. And, you know, a guy in a little community hospital is going to be hired now. And I saw that at Duke, when I arrived at Duke, people put in stents. I had a case, classical case, with these guys understand. I saw a patient with a second opinion. One of the newly trained interventional coordination speciality saw a patient with an unruptured 2-millimeter cavernous aneurysm. And I mean, that's, you know, no one, you don't treat that. He went inside and put a neuroform stent inside there and couldn't get the coil inside. You know, which, you know, thank God he didn't try. I mean, you know, and she came to me, you know, a year later, Gavin, can you please bail me out of this, you know? And all I could say, you know, that stent is all you need, you're cured. But I mean, you know, it's ridiculous. So the problem is that's what's happening out there. People are, because the case volume is so low, people are, you know, doing unindicated cases, and they're keeping the cases there. So I'm really worried about the field of vascular. I really am. Sheikh may disagree with me, and Lewis, but I'm worried. Which is sad. I mean, that's the whole talk. I trained for the speciality that doesn't exist anymore. I mean, it does, but it's a different realm.
Jake?
Gavin does a very nice talk. I think, first of all, I'm really proud to have Gavin back here. Also, I'm very proud to be associated in some way with his training and his contamination. But I just want to say a couple of words, a couple of things. I think with regard to surgery versus endovascular, I think that people need to approach it with an open mind. Obviously, vascular surgery is very, let's say, sexy, regardless of what you do, whether it's microsurgery or endovascular. But I think going forward, you can only look 10 years forward. I believe that microsurgery is still going to be in demand. The problem, as you correctly stated, Gavin, is that there are so many people trained in endovascular technique, but with minimal training in microsurgery, so that many aneurysms, for instance, that can have a good microsurgical solution, but a bad endovascular solution, they're going to choose the bad endovascular solution.
Absolutely.
Because they are not able to do the microsurgery, which is going to be more and more complex. Which creates a unique problem. Those who are able to do the microsurgery are going to be in greater demand in some ways. And programs like ours, where the residents get really good exposure, and you know, if they do a fellowship, they're even better off. Whereas there are other places where they've never seen a bypass, never seen adenosine arrest, never seen you know, clipping of anything. For instance, they are going to be at a disadvantage. I want to focus a little bit more about what is the future of vascular surgery. I personally think there are two things that we need to talk about or think about. One is, you know, how do we prevent aneurysms and strokes from happening in the first place? So this comes down to genetics, receptors, etc. So that's one area which residents should be interested in. For me, the most exciting area right now is stem cells because
Shank, we share. Phil, can you stand up?
because I think that a lot of people that are disabled after subarachnoid hemorrhage or after surgery or endovascular therapy, whatever it is, we have some fledgling programs going here which now are decapitated because of stealing of our good person by Gavin Britz. However, I do believe that that's going to be the future. I think we had Gary Steinberg here, I think about a few months ago. He's talked about his research into the stem cell arena. I believe, for instance, putting in combination of neural and mesenchymal cells into patients with severe subarachnoid hemorrhage or strokes, etc., has a very bright future because we need to be thinking about what to do with all the people who were left disabled, after. What about all these young people who come in grade 4 and 5 subarachnoid hemorrhage? We don't have anything to offer to them right now. Or people with strokes, who have various major deficits. The third area that I want to touch on briefly is neuroprosthetics and neurorehabilitation. Again, our program is at the cutting edge in some ways, but I think that this is going to be a major area for neurosurgery. I think 10, 15 years from now, maybe 15, you'll see neurosurgery wards filled with different types of patients with deficits. There are so many thousands, millions of people in the world with neurological deficits after various things. So we're going to be looking at stem cell therapy, we're going to be looking at prosthetic rehabilitation, and we're going to prevent a lot of these diseases from happening in the first place. So we are going down on the surgery, but we may invent new types of surgery using the current techniques.
So Sheikh, I've got my business, and I think Paul and these guys know that I on the three things. First of all, was for the neuroprosthetics, we start in a center now called Center of Restorative and Regenerative Neurosurgery, and we have in our academic, Cornell's got appointed, but that's going to be approved. That's exactly why. I think the way you're going to be treating diseases we aren't treating, even ALS, we're going to be treating with surgery, putting stem cells inside. So I think in that regard, I completely agree with you. We started up a whole center in that field, and that's why I would like to recruit Phil. But I think that's exactly in regard to about techniques. We watched the Mayo Clinic present their carotid endarterectomy data the other day. It was, Sheikh, it was outstanding. Better than mine, no doubt about it. There was endovascular guys that were there and said, "That's old school. We should push." Remember they said that, so they were defending.
Well, Fred said that he was doing, in the heyday, they were doing 200 endovascular. They're lucky if they'll do 10 in the future.
And his results.
It's gone.
Yeah, so Sheikh, you have a disease process that the pipe is blocked. As a guy that likes contracting homes, pipe's blocked, open pipe. Okay, it's very simple. Now we're developing these devices that are, they're pretty cool, but the stroke rate is not what Fred presented, which is 0.1%. And I believe Fred. Fred's an honest guy. And I think that if you are doing carotid endarterectomies surgically every day, your outcomes are going to be the gold standard. And I think you can develop any device that's going to squash the plaque. It's never going to be the same. But getting to what you said, people aren't doing them anymore. I did tons at Duke. In Houston, I'm lucky to do one every 6 to 8 weeks because they're not around. People are stenting these things. So I think that people are accepting worse outcomes based for more new devices. And I've seen it with aneurysms. I see it all the time. I'm sure you guys see the same thing, second opinions. I say, are you crazy? But it happens all the time. A new device, remember, you cannot make a name for yourself doing old techniques. So that's driven by money, technology, ego. That's what it's about.